This is chapter 10, recording floor. So when you're trying to suction a patient and you just cannot suction out what they've got going on in their airway, then go ahead and take the catheter out, log roll them over onto their side, and how carefully you do this kind of depends on whether you suspect a spine injury or not. And then very carefully clear the mouth with a gloved finger. Again, be very cautious about sticking your finger in someone's mouth, but you've got to get it out. You cannot adequately ventilate them with a bunch of stuff in their airway. If for some reason the patient is producing very frothy secretions, as quickly as you can suction them, go ahead and suction and then ventilate for 2 minutes and then keep alternating until you can actually clear the airway. Once you're done suctioning, make sure that you decontaminate your suctioning equipment. Make sure that you dispose of the equipment properly according to your ambulance's operating procedures. Other ways to control the airway so that we don't have to just sit there and hold it open. We do have some airway adjuncts that we can use. This basically on your screen is curved. It goes in the mouth and it keeps the tongue away from the upper airway. The ones to the left with the green, those have a hole that runs directly through it to allow air to go through while it still holds the tongue out of the way. The white ones to the right, they have ridges along both sides that allow the air to go in and out. But either way, they're trying to pull that tongue up out of the way to allow for air to get into the lungs. Those are called oropharyngeal airways, or OPAs. We're going to put them in if a patient is unresponsive and does not have a gag reflex. If you try and stick one of these in on a patient that has a gag reflex, now they're throwing up, now you have to suction, now the stuff that they're vomiting up is too big for suction. You're just going to make a huge issue. Your patient can be still breathing, or they can be apneic, meaning no spontaneous respirations at all. If they're apneic, you're going to go ahead and ventilate them with a bag valve mask. If they're breathing on their own, but you just want to keep that tongue out of the way, go ahead and throw in an OPA and call it a day. If the patient still has a gag reflex, you will not be using an OPA. Instead, you can go ahead and use a nasopharyngeal airway, so an NPA. This is used with patients that still have a gag reflex, but they're unable to maintain their airway by themselves. So this ends up going into the nose and curving down into that airway to make sure that the tongue stays up out of the way. If the patient is semi-conscious or unconscious, semi-conscious patients that have had a seizure or they're just super confused that still have an intact gag reflex can use an NPA. If they just will not tolerate an OPA and they need it, so maybe not a full gag reflex, but it causes massive secretion, etc., because their airway just gets super angry about it being in there, then you can go ahead and try and use an NPA. Contraindications. If you have a severe head injury with blood in the nose, or if you have had a fracture to the face, you're going to want to consult medical control before you ever think about putting that NPA up there. You have a bony plate that protects everything that's in your nose from being able to go straight up into the brain. If that gets fractured, there is a potential that you could start jamming that little tube up somebody's nose, and if it hits that plate and that plate has a break in it, it can go straight up into the brain, and we certainly don't want to do that. The recovery position we've talked about a couple of times. This is used for a patient that does not have a suspected spinal injury. You roll them onto their side, bend the upper leg to keep them there, kind of rest their head on their arm, This will keep that tongue from relaxing back into the throat. So these are for patients that are spontaneously breathing, and you want to put them in this position to prevent them from aspirating if they were to throw up. Supplemental oxygen. When a patient is hypoxic, they're not getting enough oxygen, we are going to give them oxygen. How we apply that, a couple of different ways, but anytime a patient complains of being short of breath, we're going to give them at least a little bit of oxygen. Shortness of breath is a symptom, so something that the patient tells you that you can't definitively measure. It's not a sign. Maybe their O2 sats are fine. Maybe their breathing pattern is fine, but if they feel like they're not getting enough air, we're just going to err on the side of caution and go ahead and give them oxygen. If they're not breathing efficiently, we need to give them oxygen. So we have oxygen that comes to us in cylinders. It has compressed gas inside. Some may be silver, some may be green, but they typically are all colored relatively the same, or they have markings on them that indicate that they have compressed oxygen inside. You need to check those markings on them because oxygen does have a quote unquote expiration date. So you want to make sure that it has been tested and has passed that testing. We test aluminum cylinders every 5 years and then the composite cylinders every 3 years. We have these massive units, as you can see here on the picture. Some are much bigger than others. We don't tend to move those around. Those stay affixed in the ambulance. And then we have the tinier cylinders that we can actually transport from place to place so that we can provide oxygen to our patients without having to hurt ourselves in order to get them there. The length of time that you can actually use an oxygen cylinder depends on the pressure of the cylinder, so how much pressure is still left in the tank, and then the flow rate at which you're allowing that gas to escape. Obviously, the lower the pressure, the less time you're going to have. The higher the flow rate, the less time you're going to have. That big tank in the back is going to last longer than the little tank in the front. We do use liquid oxygen containers, but not as frequently just because they tend to be a lot more expensive. They need to be kept upright. They have special filling requirements, so we typically don't use them. We're going to use mostly gas cylinders. So when you're utilizing those, make sure that you're very, very careful with them. I know they seem like they're indestructible, but you have a heck of a lot of pressure inside of that canister that if for some reason it gets punctured, you now have a bomb. So we want to be very, very, very careful. We do not ever set them upright unless we're holding on to them. If we're going to take our hands off of them, they need to be laid down, and you need to have the regulator that actually controls how much flow is coming in and out. That needs to be pointed toward you, because if it gets chopped off or something happens where you have a huge escape, you want the butt end of the tank facing away from you so that if it goes flying, not going to take you out in the process. There should be mounting brackets inside of the ambulance for you to actually hook them into so that hopefully they don't fall over, that they don't get punctured, that they don't get beat up. All gas cylinders have a pin indexing system. This prevents mistakes from a certain type of regulator being put on the wrong tank. So oxygen regulators only fit on the correct oxygen tank. There are certain types of pinholes that you have to line up in order for it to work. And everybody should have messed with this during lab day. Oxygen regulators fit into the specific type of tank. There's 2 pins that are positioned in a specific spot, and then there's one on the other side, and it only fits on one way. So if it's not working, check to make sure A, that you have the right regulator, B, that you're positioning it correctly, and C, that there's not something broken inside that's preventing it from going on correctly. Pressure regulators, this allows the oxygen to be delivered at a proper therapeutic range. Typically going to be 40 to 70 psi. PSI is what we measure pressure in. We don't want to take that compressed gas and just open it up without regulating it, because you're going to end up blowing your patient away. So we're going to take these regulators, and they actually control the amount of pressure that is released from the tank at any given moment. And then you end up connecting something else to it to actually regulate the flow. So you have to reduce the pressure, and then you can attach a flow meter to it in order to adjust how much oxygen is released. A lot of our regulators are permanently attached. The ones that we use, the pressure regulator and the flow meters, are permanently attached. So you don't need to attach one onto the other. They used to actually have to do this. We don't now. There's 2 different types. There's a pressure compensated flow meter. So it's affected by gravity. It always has to be upright. You can't flip it over the other way. And then we have the board on gauge flow meter. This can be used in any position. This is typically considered outdated, but when we're moving around, those portable tanks, still what we tend to use. One thing we need to keep in mind is that there are some hazards to utilizing supplemental oxygen. First and foremost, combustion. Oxygen itself, just hanging out, does not burn or explode, but in order for there to be fire, you have to have oxygen present. So when you already have a small spark, like a glowing cigarette, and you add oxygen to it, now all of a sudden you could have fire. So you want to keep fire away from oxygen tanks, oxygen tubing, because it can ignite. You never want to leave an oxygen cylinder standing upright unattended. You should always know where your oxygen tank is. You can actually give your patients too much oxygen. We tend to give more patients oxygen than truly need it. And sometimes this can actually have a detrimental effect, especially in those that have COPD. If you give them too much oxygen, it actually can decrease their respiratory drive. What we're trying to do is give patients enough oxygen that they stay at or above 94%. Again, if they are complaining of shortness of breath, we're not going to withhold oxygen because they're sitting at 98. But it has been determined by the American Heart Association that 94 is pretty adequate for somebody that is experiencing any sort of medical emergency. The exceptions to this are patients that have been exposed to carbon monoxide. Overload them, because hemoglobin would rather bind to carbon dioxide 100 times than it would rather bind to oxygen. So we actually have to overload them so the oxygen knocks those off so that they can have enough oxygen in their blood.